Next, I'd like to invite Dr. Ashutosh Wechalekar, Professor of Medicine and Hematology at University College in London, who is probably the person best suited in the world to talk to us about the adjunctive use of doxycycline in amyloidosis. Thanks.
Thank you, Jeff, for the introduction, and thank you for arranging this fantastic symposium and for inviting me to participate in it. And also thanks to Giovanni and Suzanne for introducing the topic so well, covering most of the stuff, and I think I've only got a little bit to do within the doxycycline and hopefully convince you that it is something that merits further study in patients with amyloidosis. So these are my conflicts of interest, and as you can see, there's nothing in a conflict of interest with doxycycline, and I do hope that I have somebody who takes up doxycycline for further study in amyloidosis. So we heard 4 very clear facts in amyloidosis so far. Cardiac involvement drives the morbidity and mortality in patients with amyloidosis. The survival for patients with amyloidosis has significantly improved over the years, from 1.5 years for our early cohort to going to nearly 5 or 6 years for our current cohorts. But what is also very disappointing is that the early mortality within the first 2 to 3 months following diagnosis is between 25 to 40%, depending on which group of patients you look at. And these are patients diagnosed in our center until 2008, no change. These are patients diagnosed from 2009 to 2016. These have been treated much more uniformly. And again, in patients with stage 3A, stage 3B disease, there's been absolutely no impact on mortality. And this is a real unmet clinical need. We need to target these patients. These are patients who are excluded from every single clinical trial that's done in AL amyloidosis, phase 2 or phase 3, because they are thought to be too sick. And we don't really know how to treat these patients best. That's what leads us into use of doxycycline and other small molecules to try and see if that could reduce the mortality. This story began a long time, probably a long time before any one of us on the dais who were talking about amyloidosis started treating patients with amyloidosis. This was the original study of doxorubicin and a first case report reported by Professor Mellini and colleagues from Italy. This is a patient who had amyloid involvement of the spleen. This is an SAP scan, posterior view, showing uptake in the spleen and a transplanted kidney. And this patient was treated with doxorubicin as an anthracycline for treatment of the underlying condition. And a few months later, there was pretty rapid clearance of the amyloid deposits from the organs. This then led to a small phase 2 study for looking at doxorubicin in patients with amyloidosis in general, but the company then decided not to develop the drug any further, and this never moved forward. And the reason this is interesting is because there is a lot of structural similarity between anthracyclines and tetracyclines. And these are all cyclic molecules, and we are focusing on doxycycline. So these initial observations then led to the study of tetracyclines in patients with amyloidosis. This is a study in patients with beta-2 microglobulin amyloidosis, fibrils with beta-2 microglobulin amyloidosis. You can see that there is rapid fibril formation in vitro, but then as increasing concentrations of doxycycline are added to the medium, the rate of fibril formation drops. What's much more interesting is that the normal fibrils, and all amyloid fibrils, have a 3-dimensional structure. They are beta-pleated sheets, but they also have a 3D structure of twisted chains, just like a hemp rope. And you can see these are normal fibrils, but when you add doxycycline to the medium, the twisting is gone, and these are just straight fibrils. When you watch the fibrils grow using scanning electron microscopy, you can see that the fibrils are forming as long branching chains. In presence of doxycycline, you just get these sorts of granular deposits without true fibril formation. So doxycycline in increasing concentration will affect how fibrils form with beta-2 microglobulin amyloid. Amyloidosis of transthyretin type is quite a common type of amyloidosis in the older population. It causes hereditary amyloidosis. This is a transgenic mouse model of TTR amyloid, homozygous, heterozygous, and no TTR mutations. And the pink bit is amyloid, and you can see that these mice get amyloid in the gut. True, it doesn't simulate the disease itself, but there is amyloid in the animal. When these mice were treated with doxycycline, you can see that in the non-treated mice, there was still the same amount of amyloid accumulation, but in the treated mice, there was very little amyloid in the gut in these mice, suggesting that doxycycline may block or reduce amyloid formation in these animals. There was a model of AL amyloidosis. Again, in a transgenic mouse, you have to believe that there are bits of amyloid deposits in these control mice. Nearly 70% of the control mice develop amyloid deposits, but less than a quarter of the treated mice got the same amount of amyloid. More interestingly, when you look at the fibril formation, the normal fibrils are seen here, but on incubation with doxycycline, these are broken up amorphous type fibrils rather than proper amyloid fibrils. So again, further evidence that even in AL amyloidosis with light chains, doxycycline may interfere with fibril formation. There is another important fact about amyloid light chains. You heard earlier from Giovanni that these patients have high cardiac biomarkers, and part of that is being driven by light chain toxicity or proteotoxicity of the light chains to the heart. This is a zebrafish model where you can see that when these zebrafish hearts are given control light chains, they survive longer. When they're infused with amyloidogenic light chains, they die quite early, and the ejection fraction is significantly reduced. In the C. elegans, which is another model studied by colleagues in Pavia, there are regular pharyngeal contractions, and you can use that to test impact of various drugs. And you can see that when non-cardiotoxic light chains are introduced or light chains from myeloma are given, there's no change compared to the control ones. But with cardiotoxic light chains, there's a significant reduction in the rate of contractility. What is more interesting to this presentation is that for these worms, when you add control light chains, there is no change, but when you add tetracyclines or EGCG, the effect of the cardiotoxic light chains is abrogated, suggesting that doxycycline or tetracyclines may block the effect of light chain cardiotoxicity on the myocardium. This is also very important because we have some very nice work from our colleagues at the Mayo Clinic showing that the light chains in AL amyloidosis are internalized by the cardiac myocytes. And our Italian colleagues showed very nicely, and this is confocal microscopy, showing cardiac light chains here, light chains from patients with multiple myeloma here, that the light chains will co-localize at the site of the mitochondria and cause mitochondrial dysfunction in the myocardium. The co-localization gives you the nice yellow signal, whereas you can see the separated green and red signal where the light chains in myeloma patients where there is no co-localization in the mitochondria. So there is mitochondrial dysfunction directly caused by light chains in amyloidosis. And doxycycline can protect against mitochondrial fragmentation. This is a study from heart failure, not amyloidosis, mind you, showing that when hearts are exposed to hydrogen peroxide, there is fragmentation of the mitochondria induced by the ROS. And when it's incubated along with doxycycline, there is a marked reduction in the mitochondrial fragmentation, suggesting that there may be a mitochondrial protective effect of doxycycline, particularly if the light chains are causing mitochondrial toxicity. We know in AL amyloidosis, there is a lot more going on than just amyloid buildup in the heart. In patients with AL amyloidosis, there is less amyloid than patients with TTR amyloid, and this is a study using MRI scans looking at the interstitial volume expansion in AL versus ATTR, and in ATTR there's a lot more amyloid compared to AL, but the outcomes in AL are much worse. We have 40% deaths in AL, whereas in ATTR we don't see this early mortality. Using T2 weighted MRI images, which shows us the edema within the myocardium, we have been able to show in our center that there is significant myocardial edema in patients with AL amyloidosis. Patients who have myocardial edema tend to do worse, and this myocardial edema is better after treatment. So something that could change all of this can make a difference. So we've got lots of rationale why doxycycline might be good in amyloidosis. It may reduce the rate of amyloid deposition. The fibrils may not be properly formed, so the body could clear these fibrils more easily. It may reduce light chain toxicity to the myocardium and therefore improve cardiac function even before these two things happen. And then we shouldn't forget it is a really good broad spectrum antibiotic. The commonest reason for hospital admission in patients who start chemotherapy in amyloidosis is infections. 60% patients will have one or more infections, and it might just be doing this by stopping infections and none of these fancy effects that we think it actually is doing. So what data do we have for doxycycline in amyloidosis? Here is where the story gets much more limited. There is one prospective study done by a colleague from Boston. He's sitting here in the audience and he'll correct me if I say something wrong about the study. There were 25 patients with AL amyloidosis studied prospectively. 14 of these patients completed the study. Some of these patients did not have significant cardiac involvement. They had fairly low cardiac biomarkers at the beginning. But what was important in the study was there was no impact of doxycycline on cardiac amyloidosis. These were patients who had completed treatment and were at different disease stages. But certainly in the first prospective study, which was done in a small number of patients, there was no change for those patients who were given doxycycline. The second bit of evidence comes from our colleagues at the Mayo Clinic. This was a natural randomization. Patients who underwent autologous stem cell transplant got post-transplant prophylaxis with antimicrobials. Patients who were penicillin allergic got doxycycline, the others got penicillin. There was no difference in the baseline heme response in either of the two groups, but in the doxycycline group, there was a suggestion of improved overall survival compared to the group who received standard penicillin prophylaxis. One might argue this is the effect of doxycycline, or one might argue that this is the effect because it covers atypical organisms much better, and we'll come to that later. Given the high mortality of patients with cardiac amyloidosis, we started using doxycycline in an off-label use in our center, treating patients with amyloidosis. We gave it to all our patients with cardiac amyloidosis, treated as per our UK guidelines, typically with a bortezomib-based regimen. They all received doxycycline 100 milligrams twice a day, typically given after meals until completion of therapy or toxicity or patient preference to stop the drug. What was quite important in this group was they all had what we call as enhanced supportive care. All patients were taught daily weight measurement. They would do their daily blood pressure lying and standing, and diuretic self-adjustment based on weight and blood pressure. They were seen every day by an amyloidosis consultant. We were pretty proactive in treating arrhythmias with ICDs where required. And we used blood pressure support to allow for adequate diuresis. We matched this to a group of patients in our prospective alchemy study, two controls for each patient, and they were well matched, and all patients had significant cardiac involvement. The doxycycline was typically started 2 or 3 days before they started chemotherapy. In this group of patients, the major adverse events were GI, nausea and vomiting in most patients, and then photosensitive skin rash, which made one patient discontinue treatment and one patient discontinued for nausea and vomiting. The overall survival for our entire cohort of patients, controls as well as doxycycline-treated patients, was 21 months. But in the group who got doxycycline, there was a significantly better survival compared to the control group of patients, suggesting that we may be doing something here with the drug. When we broke this down by stage 3A and 3B, 3B being those with NT-proBNP more than 8,500, this impact was much greater in patients with stage 2 and stage 3A disease compared to stage 3B disease, where we could not make any difference on the early survival for these patients. And this was significantly better than the control group of patients who were treated with standard treatment. This translated on an intention to treat basis into better hematologic responses in the doxycycline-treated group, over 60% achieving a CR or VGPR compared to the control group. But this is striking that doxycycline did not cause those responses. These patients were evaluable for response because more patients were alive. So when we did a landmark analysis, there was no difference in the CR VGPR in the doxycycline group or indeed in the control group, suggesting that patients with doxycycline were living longer and therefore we are seeing greater responses. And this is the challenge. If patients with amyloidosis can live long enough, then the responses we get will translate into organ responses. And these patients die early and therefore we don't have time for organ responses. Hopefully this drug will buy us this time. We have recently done an updated analysis. We have now got 80 patients treated in our center with doxycycline, and this is all the patients within the alchemy study, so this is about 500 patients with stage 3 disease. And there is still a suggestion that patients who are treated with doxycycline have better overall survival compared to our overall group of patients where the median survival is 19 months. Chemotherapy is critical, and getting a response is really important. When we looked at patients who achieved a CR or VGPR, whether they were doxy-treated patients or control patients, there was only a slight difference in the survival, and the non-responders all did very badly. So it's not a replacement for chemotherapy, it's not a replacement for achieving a rapid response. Patients who had treatment with doxycycline seemed to get deeper cardiac responses, so we had greater reduction in NT-proBNP. For the entire group, as well as for the patients who achieved a CR or VGPR, we still had the median NT-proBNP was probably half in the doxy-treated patients compared to the control patients. Again, lending maybe weight to the theory that in some patients, doxy may impact how the fibrils are forming, and therefore the body is able to clear these fibrils better. Patients who had a cardiac response, irrespective of what group they were in, doxycycline or controls, all had very good outcomes. So if you achieve a cardiac response, the doxycycline doesn't really matter whether you're in a control group or the doxycycline group. When we did a multivariate analysis, the standard prognostic factor, proBNP, low blood pressure, and high free light chains was significant, as was patients who did not receive doxycycline. There was one interesting fact. We think doxycycline may block cardiac toxicity, and high troponin is one of the markers for myocyte damage. When we looked at the impact of troponin, which is a marker for poor prognosis in AL amyloidosis, in the doxy-treated cohort, to our surprise, the troponin did not stratify the patients, whereas in the control cohort, the same troponin level stratified the patients quite dramatically. It may well be that the doxycycline was blocking the toxic effect of cardiac light chains and reducing myocyte damage, which is what this might be showing us. We did a landmark analysis of patients who were alive after 6 months, and again, receiving doxycycline was an independent predictor of better outcomes. In the UK, the use of doxycycline is still variable. Some people use it and others don't. We would typically start it 48 hours before we start a bortezomib-based regimen. We give it 100 milligrams BD after food. With increasing experience, it's become very clear that doxycycline is a drug which is well suited for the cloudy climates of UK and may not be suited everywhere else. Certainly photosensitivity is a big problem, and patients will come off the drug during the summer months because they will have photosensitive skin rash, and we would counsel the patients for using proper sun protection even in the winter. If you give it with amiodarone, it's certainly a serious problem that they even get indoor photosensitivity even if they're sitting next to a window in the British winter. We would have continued it for the duration of chemotherapy if the patient tolerates it. And for some patients, they refuse to come off the drug because they think it's helping them. We don't quite know what to do with those patients, but they continue the drug as long as they tolerate this drug. This is just a cautionary tale. This is a study which was presented last year here at ASH. This is the TEAM trial from the UK, where patients were randomized with multiple myeloma to receive levofloxacin prophylaxis versus placebo. And there was a significant reduction in febrile neutropenia and death in the myeloma patients who were treated with levofloxacin compared to the placebo. And therefore, the antibiotic effect of doxycycline cannot be ignored. And we have to be careful when we start attributing survival to these based on small studies. So to conclude, doxycycline with meticulous supportive care does appear to improve survival in cardiac amyloidosis. This impact is particularly true in the early stage cardiac patients compared to the late stage, but even the late stage patients may benefit. It only has an impact if we use it with rapidly effective cytotoxic chemotherapy. And this data certainly supports a randomized study for doxycycline. The message is clearly out there. These are the current trials going on around the world with doxycycline, US, Europe, and in China. And we have a pivotal phase 3 study that is hopefully going to start across many centers in different countries around the world, supported by an organization called eRare and led by Giovanni here, where patients are to be randomized to doxycycline versus standard supportive care antibiotics. And hopefully this will answer for us the question about the impact of doxycycline in AL amyloidosis. Thank you.
Thank you so much.